Well, hello and welcome again to Medical Mastery, the podcast of the Emerald Coast Medical Association. I am pleased and proud to introduce our next guest, Dr. Jeremy Sunseri. Dr. Sunseri, a former president of the Emerald Coast Medical Association, who led us at a difficult time and brought us through to the point where we are today. And I stand on the shoulders of giants trying to lead this organization in the same way.
Shoot.
Now,
your exemplary leadership,
oh, stop that,
Donnie, has just made me look like I didn't even attend.
That's completely untrue. But love fest aside, let me start off by saying it is a pleasure to have you here. Dr. Sunseri is owner and operator of Sun Dermatology and has been here in the community how long?
10 years-ish.
10-ish years and has been through Hurricane Michael and then some. And we're going to talk about all those things. But first off, why don't you tell us about where you're from?
Where I'm from? My mom.
It's true.
Most directly.
Yes.
No, I grew up in Utah mostly. I spent a little bit of time living in California, but then after training went to Washington State, Rhode Island, and then finished my fellowship here in Tallahassee, or over in Tallahassee, which brought me here to the Panhandle.
Yes. So let's talk about that. So where'd you do your undergrad?
Weber State University in Ogden, Utah.
Well, I knew that it was in Ogden, Utah. Everybody knows that. But either way, so I'm glad you told the other people that wouldn't know that. What did you major in?
Microbiology.
Okay.
With a minor in chem.
Minor in chemistry. Okay.
Yeah.
Now, did you know you wanted to go into medical school? Was that something that you were really interested in?
I did. I always knew I wanted to go in medical school, but I just wasn't sure if they would ever let me in. So I was like, I'm going to try to do it. Whether or not they'll let me in, I'm going to do everything I can in my power to make it happen. So I did, and they won school.
Gotcha. Okay. And where was the medical school?
University of Utah.
University of Utah.
Being a Utah boy, that's the only state that ever showed me any love. So until I got to Florida.
Now you're getting some love from Florida.
Yeah,
okay.
Yeah.
Now, what did you? How did you get through your undergrad? Did you have any scholarships or anything?
I did. I was on the rodeo team. My drinking team had a rodeo problem, and we used to. It was a lot of fun. So I did do college rodeo, and then I was also involved in some student leadership stuff as well. But college rodeo was my escape, and honestly, I think the thing that probably allowed me to get into med school and residency. Nobody cares about anything that I did research-wise or academically. I put most of my efforts into that basket, and everybody looked at them and was like, we don't care, but you used to ride bulls?
You rode bulls, yes.
Yes, come, we want to interview you. I'm like, are you kidding me right now? I spent 3 years doing this research, and nobody even wants to ask me a single question about it. You're an MD, PhD, why you want to talk about bull riding? Come on, like. Anyway.
Well, I mean, look, not too many of our membership are going to be professional bull riders at any point in time. And if I recall correctly, did you do pro bull riding?
I had a PRCA permit. So.
Wow.
Yeah.
Okay. So for the novice, I mean, I've ridden a ton of bulls, but for those that maybe haven't, why don't you tell us about what that's like?
What riding a bull is like?
Yes.
Oh, man. It's hard, I guess, to explain. There's a lot of adrenaline, so I think that's what drew me to it, is the adrenaline. My grandpa was the one that kind of helped push me into it, but you got so much adrenaline, you can't really even think straight. And I always give the analogy of if you've ever been in a car accident and it seems like everything was on fast forward but on 10 times slow.
Yes.
So you can see every single little thing, but then it's also like it happened like that. That's what it's like. I feel like every time you would ride, it's like it happens so fast you can't but you can also see every single little step in slow motion, which is kind of weird. I guess it's probably the adrenaline and the sympathetic response, but it was awesome. I felt like when you get it right, you feel like Superman. You just rode a bull for 8 seconds, and you feel invincible.
Yes.
And when it's wrong, it feels really wrong, and it does feel like a car accident. Really,
it's more damage than a car accident. But
I always say if you're riding bulls and you get hurt, most of the time you can't really feel the pain until an hour or two after some of that adrenaline drains off. But before that, if you get hurt and you feel it instantly, you know it's a bad one.
We got some problems here.
Okay,
yes.
I got problems for sure, because I felt that as soon as it happened. My shoulder got pulled out. I felt it immediately. Ribs, like the real bad stuff. You're like, right then and there, it's terrible, and you're like, that's gonna suck.
Yeah, didn't you have? I mean, I don't want to catalog all your injuries, but didn't you have your pelvis crushed at some point?
No, not my pelvis. Femurs and ribs and shoulders.
So nothing major. I got you.
Yeah,
okay.
Yeah, nothing major. Concussion stitches, a couple broken bones, but radius ulna, just.
So after injuries like this, and doing something that seems to most of us pedestrian folks like just pure craziness, why would you go back?
Chasing the dragon, man.
Yeah.
That's the best drug that there is.
That thrill?
Adrenaline,
Yes.
man.
Yeah.
Go back and chase that. But I don't know. I loved it. It's fun. It really is fun. It's a fun sport. It is crazy, and I think most people are too smart to do it. But I have this lack of frontal lobe thing, and so I don't have a lot of inhibition about pretty much anything in life. Unfortunately, my wife will tell you all about it. But I just, I see something, I'm like, yeah, I'll do it. I'll try it.
Yes.
And for me, once I did it once, it was like, oh, I'm doing it again and again until I finally, at first it was trying to be able to cover one, which means ride it for 8 seconds.
Okay.
So then once you cover one, you're like, oh, now I got to do it again. And now I got to win a buckle. I covered it, but it wasn't worth very many points. And now I got to get the buckle. So then you keep going and you get a buckle. And then you're like, all right, now I got to win this or that. And you just keep chasing the dragon, keep chasing those dreams.
Now, when you think about it in hindsight, or maybe while you were actually doing it, is there really a lot of science to it? Is there more technique than we see if we ever watch a bull rider? I mean, it seems like you're just strapped in on a rocket and let go. I mean,
So this is kind of funny because I don't know, it's about as opposite end of the spectrum, but I've recently started playing golf, and I freaking love golf. And
I didn't have that on my Jeremy Sunseri bingo, by the way, but either way, okay.
But I love golf, but and now I'm drawing a blank on the someone like Phil Mickelson or somebody says the greatest distance in golf is the 5 inches or 6 inches between your ears, which golf is a very mental game, and you can beat yourself up and put yourself in. And bull riding is no different. If you think of it as, and there's some Gary LeFew, this pro bull rider, but I bought this cassette tape of him talking, but he's like a world champion, and he was saying that if you think of yourself as a little mouse jumping on this bull who is ginormous, then you're going to get bucked off. If you think of it as you're Superman and you're jumping on this bull's back, then you're going to have a lot better chance of riding the bull. And it is very, very mental. I mean, if you believe that you're not going to do it, you're not going to do it. But if you're like, I can do this, and I'm going to do this, and there ain't no way I'm going to get bucked off, I'm going to cover this bull no matter what, then I think it becomes much easier. It's just like anything else. It's a lot of technique. So in riding horses or riding motorcycles or anything like that, everybody knows when you're riding motorcycles. If you look down, that's where you're going to go. Bull riding and horses, it's the same thing. If you look towards the ground, that's where you're going to go. So you just got to stare right in the middle of their back. And that's easier said than done if they run you up to a fence and start smashing you into the fence. As soon as you look at that fence, you're going to grab it, and jump off. If you just stare right in the center of that thing, it doesn't matter what's happening around you. You just stare right at that hump on his back, and you can cover it and stay on it. So it's a lot of mental, a lot of technique, just like any other sport, golf included.
Well, I mean, it seems like, if you're going to talk about F1 racing, that's going to go on for 4 hours, something like that. For 8 seconds, it doesn't seem like there's enough time for you to be able to really get this technique down. But I mean, and also how you get injured yet still go back. I mean, that's just
adrenaline.
It's a testament.
It's a great drug, man. But again, it is. It's all about technique, man. You stick your chest out, tuck your chin, look at that spot on their back, right at their hump, and keep moving forward, and you can ride a bull. That easy. It's that easy.
What? I'll take your word for it on this one.
Yeah.
Okay.
Dang it, Donnie. I know you do good at it.
Oh, stop that.
We can start with some steers, man. We put you on some
they
steers.
don't make them small enough, all right?
They do.
Shetland pony, maybe.
Those suckers are mean now. They'll kill you. Those suckers will hurt you.
So I could talk about the bull riding for a long time, and I love that you wanted to kind of bring that, the Venn diagram overlap of bull riders and dermatologists has to be extraordinarily thin. I can't imagine there's a whole lot out there. So you can already get an idea of you're a pretty unique personality, and that's awesome.
Just weird, yeah.
Hey, tomato. So you did medical school at Utah. Then where did you do your residency?
In Providence, Rhode Island.
Okay. Now, 3-year long residency that you did?
3 years, yeah.
Did you do an internal medicine year?
I did my intern year through the University of Washington Sacred Heart, Providence Sacred Heart, which is in Spokane, Washington. Transitional year.
Yes, transitional year. That's what the smart dermatology residents did. So
that's what they tell you online. They're like, "Ooh, if you want to have the," I'd love my intern year, man. It was good. It was a good time.
I love mine too, but I met my wife, so that was a little different. Now, so for perhaps some, because this is going to be hit out to hopefully a wide audience of several different medical professions, but also maybe some patients as well. So your first year, you can do one of a number of things if you're going to go into certain subspecialties like dermatology. You can do a surgical intern year. You can do an internal medicine intern year, or you can do a transitional year. And maybe talk about what that implies.
So a transitional year is kind of supposed to be, I think, a hybrid combination of both your internal medicine, but also surgical specialties, subspecialties. And I spent, I did like an ICU rotation. We did a lot of surgery. I think it was probably like 7 or 8 months of surgical months. Yeah. And then we did internal medicine, ICU, I think like some kind of internal medicine subspecialty. And I started in cardiology, but they had these dang graphs that you're supposed to learn how to figure out.
I don't know. I can't help you on any of that. Yeah. Okay.
It was so confusing. I'm like, all right, I transferred. Let me do GI. I know my stuff.
Yes.
But yeah. So.
Now, look, there's part of that that's really interesting because, if you're going through internal medicine like I did, I wanted to get in the ICU. I wanted to kind of learn those things and take care of critical care. If you're going into dermatology, that's not necessarily your dream scenario to go and take care of really sick patients in the ICU.
Yeah. I will say this, though, that I had some really remarkable experiences on my ICU rotation that just about changed my mind and swayed me, and I was just about I was like, maybe I'm meant for the unit. Like, maybe I need to be an ICU doctor.
It's that adrenaline. It's the bull ride.
Exactly.
Yep.
I had some really cool cases that were just amazing that, like, things worked out for the best. And afterwards, I was like, dude, I don't think I'm supposed to go to dermatology. And so much that my ICU attending on one of my reviews or whatever, the evaluations wrote, you're a perfectly good waste of, you're wasting your intelligence in dermatology or something like that,
Yes.
and you need to go be an ICU attending or whatever. And I was like, man, but I love the ICU. I love just that adrenaline. I like ER and that kind of stuff. I probably should have done that.
Well, look,
but
I think you did okay. I would never have thought going into it that I would like the ICU as much as I ended up liking it. It was a totally different experience for me for the first time. And, one of the things that I really found compelling about it is all of a sudden you had a lot of control over the physiologic variables. I could change a lot of blood pressure and heart rate and other things. And you had a lot more marionetting that you could do for those kind of things, which was really interesting for me for the first time.
yeah, I wasn't that smart, so I didn't figure out all that. I was just stopping people from dying, like CPR.
Look, that's half the battle right there. Recognizing sick versus non-sick. If I can take
You're
residents and treat them.
You're in there fine-tuning, like, we're going to turn the FiO2 to...
Weaning down ventilator settings is very important.
Exactly.
So now,
exactly.
Your persona is such that you really have this disarming style where you are, oh shucks, yeah, I'm just a guy who rides bulls. But I think that belies how difficult it is to get into dermatology residency. That is really for the highest achieving amongst us. I can tell you my application for dermatology would have been rendered toilet paper. They would not have even looked at that. So as much as I appreciate the things that you're saying, really, dermatology is such a difficult field to get into. And let's maybe kind of analyze why that might be. Do you have thoughts about it?
Absolutely. It's lifestyle and call. I mean, it boils down to lifestyle, right? Like,
I'm going to take a different approach.
And everybody says, hey, look, if I can work 8 to 5 and pop pimples and have low risk and high reward and like no weekend work and yada yada, then why not do it? And that's why I think it's become popularized. But then you get in there and you're like, I'm a dang dermatologist. I'm working longer hours than my general surgery buddy, who I'm like, I can't be at the meeting tonight. I'm doing
stuff.
They're like, you're supposed to be a dermatologist. Alex Jones always says, we always joke about, I thought you were a dermatologist, man. Why are you still working?
What are you doing? You're doing it wrong.
Exactly. I am doing it wrong. I know that. I work way too much, and I haven't figured out the good part of call and whatnot. But no, and again, the only reason I got in was because of the rodeo thing. I mean, 100%. Like GPA, USMLE Step 1 scores, none of that was like, I was not I mean, I did okay, but none of it was like, oh, this is that rock star derm guy. It was all, oh, this guy used to ride bulls. Let's bring him in and meet him. And then they met me and they're like, yeah, he's pretty all right. Maybe we invite him a spot. So
I'm going to take the other end of that and talk about really where dermatology is incredibly difficult and taxing is that it's about 95% of your time is on 5% of the cases. So in other words, you have to know this encyclopedic knowledge of all of these different conditions, 90% of which you're never going to encounter ever in your entire professional career, even 100%. If you see a ton of patients. And so you still have to be knowledgeable about that. Dermatology boards, I would think, would be next to impossible for my kind of brain power, how that works. But I mean, it also, all my all my dermatology friends can read a book and just get it. Now, did you find yourself in that similar boat, that similar skill set?
Yeah, I am not, I guess, and I don't. Let me back up and say I'm not belittling dermatology and saying that it's all out. I think,
of course,
there are people that go into it for that reasons, for those reasons. But there are more diagnoses in dermatology than any other specialty, and most of it's minutia, and most of it you will never ever encounter or see in your life.
Yes.
And for me, I always had a good memory. I could read things and remember them. I'm dumb as hell. All right, but I can remember things. So I'm not one of these real critical thinkers where, like a cardiologist reading EKGs and stuff. Like I can't. That goes
The
way
machine
over.
tells me what it says.
It goes
That's
way
it.
over my head. But I can read something and remember it for, and that's always been, I think, one of my. Again, I'm not a critical thinker, but I can remember some stuff. So for me, the two kind of made sense of being able to I just got to remember all these 36,000 diagnoses and I'm good.
So, I'm still impressed because, again, that's just not my strong suit. So those that can do that is really always impressive to me. So now, but, you didn't just stop there. You went on and did a fellowship. Let's talk about that. Where'd you go?
I went to Florida State University and did a fellowship in procedural dermatology in Mohs, and I can't remember the exact name of it, but it's something along those lines.
Yes, exactly.
Procedural something Mohs fellowship. Anyways, considered a Mohs fellowship. It was a year long. There are a lot of people that don't do fellowships, and I interviewed at some programs. Texas Tech was a program I interviewed with, and like that was their bragging point of like, hey, if you come do your residency here, you will not need a fellowship because you're going to get so many Mohs cases that by the time you leave here, you're not even going to need a fellowship. And when they told me that, I was like, I don't know why you discourage somebody from doing a fellowship. Like, to me, it kind of bothered me. And again, I'm sure they're great, and Yeah. I was like, to me, doing the fellowship was less of, let me get this pen in my cap, but it became more of like when insurance companies start looking and scrutinizing things like, is this person supposed to be? And it turned out, I was 10 years too early because they just now are implementing that. And so I totally could have done it and got away with it. But again, my thinking when it was time to do my fellowship was, yes, it would be nice to go out and start making money. And yes, it's going to suck to stick back and still get fellow pay and not really earn anything while my family is young and starving in debt.
Yes.
But at the same time, I feel like if I knew I would never go back and do it, if I went straight out and practicing, I knew I would never take that time. Once you start earning, it's hard to go back. And so for me, it was like, I got to do it now or never. And for me, I always just thought, I had great training in Mohs during my residency. I had some really great attendings. Felt like I could do it out of school, right out of residency. But I thought, man, why not? It's only a year, 365 days, and the worst that could happen is I could learn a thing or two about a thing or two when it comes to Mohs. And so I did, and I learned a thing or two about a thing or two, and then some.
Well, there was, I remember coming from internal medicine residency and going into cardiology fellowship, and at the time I had done a lot of cardiac rotations. I had run the CCU. I had done all these kind of things, and I knew a fair amount of cardiology. I didn't know anything about cardiology. Exactly. I found out very quickly. I was like, oh, this just exposed me. It was Dunning-Kruger in full effect here about how I didn't know anything. It took fellowship to teach a lot. I didn't know anything for that.
That's how I felt after my end of my fellowship. I'm like, man, I thought I knew. I didn't even know.
It wasn't even close, yes. Now, maybe we should talk a little bit about, for those of us that don't know, how do you go through dermatology and get back what seems more of a medicine specialty, and you go back into surgery? Tell me where Mohs fits into that.
Oh, yeah. So I guess, so when I was a first year med student, I'm going to say first, second, or third year medical student, if you told me that I was going to be a dermatologist, I would have laughed and said, get the hell out of here. Like, I ain't no dermatologist. And so for me, I always wanted to do something surgical. And so I finished, I started my rotations as a third year med student or whatever. And I did some before, but so I started in surgery and like general surge. And I'm like, ooh, this is not my personality. And
they're different.
I quickly learned that was probably not for me. And then I kind of went to transplant surgery, then surgical oncology, and I really loved all of them.
Yes.
But as a med student, I just remember thinking, look at the attendings, and maybe that's not the best way to do it, but I just thought, let's look at the attendings and how they are, act, interact, feel about life. And like I do these rotations with general surgery, and they were like miserable bastards. I mean, they hated everything.
Lot of them,
like
married to each other and still miserable.
Exactly.
Yes.
Like absolutely have to, and I'm not I understand like it's a high stress job.
Yes.
It's I mean,
we need
absolutely. But I left there and I thought, yeah, that ain't me, babe.
That's right.
I don't know what I am, but that's not me. So finally kept getting kicked down the line in the surgical specialties, and I end up in plastics. And I'm like, dude, this is it. This is the one. I finally found my happy spot. And the chairman of the department that I was working in, awesome guy, just really, really classy, good guy. Kind of took me under his wing and was super kind. And I started doing research with them and some of the residents, and they're like, hey, like, you want to do plastics? You got a spot, basically. And I was like, okay, perfect. And like I said, I was doing research with them and doing all kinds of, rotations and trying to get any chance I could to get in and get my foot in the door. And then I found myself really liking in plastics the things that are measurable from a specialty standpoint or from a standpoint of lifestyle. So I really liked, microsurgery and tram flaps and these things that take forever, and people don't wait to cut their fingers off till 8 a.m. They'll do it at 2 a.m. and you got to go in. And so and I'm thinking, man, I really love so I had this conversation with a buddy who was a resident in dermatology, a good buddy of mine, and I was telling him my woes of plastics. Like, I love plastics. I really love it. So, but the things I like are all kind of, the reconstruction. I love the reconstruction. The problem is that that's not where the lifestyle of plastics is. Like, you do reconstruction, you're going to be at an academic center, and you're going to be doing whatever you get told to do whenever, middle of the night, whatever. And so I started, he said, well, you should check out Mohs surgery. And I almost laughed at this guy. Like, Mohs surgery. Like, I've never even heard of that. That sounds ridiculous. You're doing mole surgery? What? Like, he's like, no, it's Mohs surgery. I was like, okay, sounds really interesting, and I'm sure it's great and everything, but I like plastics and I stick with that, And so a couple days go by and he calls me. He's like, hey, I talked to our attending Mohs surgeon, and he said you could come spend a day with him if you wanted to. And I was like, all right. I was like, there's no way I'm going to do this, but now this guy's gone out of its way to, it's like, okay, I'll go spend a day with this guy and just see what it's like. So I go in there, and this guy is doing like really complex medical derm stuff in between his Mohs cases, like cutaneous T-cell lymphoma or T-cell lymphomas and all this really kind of crazy or weird stuff that I'd never even heard of. And then he'd go in and he'd do some like flap on the nose or a forehead flap or something like that. And I was like, what? This guy is a dermatologist?
Yes, it's so
and
weird,
I could
right?
do a Monday through Friday gig and still do this? Are you kidding me? Where do I sign? And so I went and I did a couple more rotations just to make sure I really liked it. But this was like fourth year. Like, I'd already started my application to plastics.
Plastics, yeah.
The guys had already written letters. Like, I was in pretty deep. And so I said, hey, I think I want to do this, and would you be willing to support me as far as my application goes? And they're like, yeah, let's do it. So one of the hardest conversations I've had to have in my life was going into the chairman of plastics at Utah and saying, "Hey, all this time that you've spent for me and the letters, and I think I'm going to be a dermatologist." And I felt like he was very, very kind, and like I said, he was a classy guy, and he said, "Hey, you need to do what makes you happy, and that's what's going to make you happy, do it." And I said, "Okay, well, I don't know what's going to make me happy, but it's pretty cool stuff, And so I jumped ship and said, I'm going to be a Mohs surgeon. So before I even decided that I was going to be a dermatologist, I was going to be a Mohs surgeon
first. That was the path.
Yeah, I had no idea or no inkling that I would ever I'm going to do general dermatology or derm path or anything like that.
It kind of shows what being a good mentor is like, which is you're going to somehow or another get whatever pupil you have to the right direction, the place that they need to be.
Right.
And it certainly seems like this is the right direction for you.
Yeah, I guess.
Well, now, having said that, so can you elucidate what Mohs surgery is compared to what regular surgery is?
So Mohs surgery is basically you are the surgeon and the pathologist at the same time. So we're cutting out skin cancers. We process it real time using a cryostat, which is fresh frozen sections, so that you can process it pretty quick. And then the guy who cuts it out is also the guy who's looking at it under the microscope. And for me, that was like a huge bonus because I'm a nerd. We're all nerds, right? But from my standpoint, one of the things about plastics that I felt was maybe not right up my alley was I felt like after a while I was a technician, and I was just doing and sewing and doing and sewing, and I wasn't thinking. And so for me, when I saw Mohs, I'm like, wait a minute, so I could do surgery and do this cool reconstruction, but then I also have to know the pathology and look at it under the microscope and make those calls. I'm like, yes, that seems awesome. So for me, that was it. Like, that helped make that transition of enough nerdiness, but also some cool surgery and reconstruction. So basically, we cut out skin cancers, check it, make sure the margins are clear ourselves, and then once that's clear, we put it back together. And I think there's a lot of variability between Mohs surgeons on what they're comfortable doing as far as reconstruction. And I think there's probably something to be said about fellowship training with reconstruction, but I also know some programs that are fellowship trained where their fellows aren't very good at reconstruction. And so it's pretty variable among Mohs surgeons. Like, how comfortable are you at doing a forehead flap or doing, various types of reconstruction? And because I think I spent so much time with the plastics guys, like, I loved it. I ate it up. And to me, that was the best part of it, was putting the thing back together, the reconstruction of it.
Well, this is my naive interpretation, is that you are actually doing plastic surgery. I mean, that's effectively what you're doing.
It's reconstructive surgery.
You're just also throwing in a wild card. You're like doing a biathlon where you ski and then shoot a gun here. You're also doing the pathology.
Exactly, which is why I liked it. And I felt like the diversity of it would be more challenging in the long term, because I get bored easy.
Yes.
I get super bored easy.
Yes.
And so for me, I'm like, ooh, I got to still challenge myself with the pathology, the reconstruction, and to me, I'm like, that's it. That's my kid.
I love that you said that, because kind of throughout our training, we're kind of exposed in regular intervals to new challenges. Oh, now I'm doing undergrad. Now I'm going to do medical school. Now I'm doing residency. Now I'm doing fellowship, and it kind of goes on, and then you kind of hit. For the first 10 years of my career, I was most concerned, can I actually do cardiology? Can I get out there and do that? And then all of a sudden, once the imposter syndrome kind of falls a little bit more to the wayside, you say, oh my goodness, I can do this. Well, now what?
And I'm damn good. But yeah, then you're like,
now what am I supposed to do? Because I've been trying to flex these muscles for so long here. What's the next challenge that comes along? So you kind of built that into your own training about, which I love.
Yeah.
So now, what is a typical day like for you out in your practice here?
So it's variable. I think I still do about 1 or 2 days a month of general dermatology, which is skin checks and whatnot. And
are those your favorite 1 to 2 days of the month? Is that right?
It is the bane of my existence, and I'd rather eat chalk and do other stuff. But I'm not it's okay. To be honest, there are days where I've done so many surgery days consecutively where that Gendrum day comes and I'm like, thank goodness, because I needed just a second to breathe because my back is killing and I'm tired. But as far as surgeries go, most surgeries will typically start with 4 in the morning, we'll process and clear those. Hopefully 1 or 2 of them may keep going and keep going. The problem with Mohs is you can't predict it. It's very unpredictable.
Yeah, you don't know what you're getting into, really.
Exactly. So some days are awful, and it seems like every single person is going to be
get into? Yes.
Like on the same day, I'm like, who's arranging this schedule to where every single one is positive?
Does it have to be everyone?
Exactly. And then the next day you'll go in and not one will be positive, and you're like, why couldn't this have been kind of half shifted to this day? But it's just how it goes. But so we'll start out usually with 4, clear that. I usually have like a 10:30 patient who's our toughest patient of the day, the biggest hole, the toughest reconstruction. And then we have 3 to 4 more at 1 o'clock. So anywhere from 9 to 12 patients a day of cutting out the skin cancer, checking it under the microscope, and then putting it back together. And some of them are pretty simple, put back together, sew it in a straight line, and those are nice sometimes. And then sometimes you're cutting somebody's whole nose or whole ear off, and you're like, oh, dang, this day just got real long.
Yeah, it did.
Honey, I'm not coming home.
Yeah, sweetheart, if
midnight.
You could just put the dinner in the oven. Well, what's the longest surgery that you've ever been in?
Are you talking for Mohs?
Or just anything?
Whipple.
Yeah,
Whipple.
Okay,
Yeah.
so doing more GI surgery based.
Yeah, cancer, okay. GI surgery.
How about the longest Mohs surgery or plastic reconstructive surgery?
So Mohs is a little. So I've done some tram flaps in plastics. They take a minute, but some of the Mohs cases, the hard part is that it's spaced out, right? Because you're cutting out the tissue, it gets processed in the lab, and they bring it out on a microscope slide, and then I got to read it. So if somebody comes back positive multiple times, they can be there all day long from 8 a.m. till 7 p.m. When I was a fellow, somebody went like 14 stages once, which is crazy. But I've had them go, 7, 8, 9 stages of where you just go back, check it. Every time you check it, it's a half hour.
Yeah.
So you're not sitting just doing surgery. As far as reconstruction, something like a forehead flap where you're taking the forehead and making it into a nose, that can be one of the longer ones. But any big, giant reconstruction, we had a big melanoma on a younger lady's face that took a couple hours to reconstruct, probably 2 or 3 hours to reconstruct it. And I'm also really meticulous in like OCD, so there are people out there that are way faster than me. But I'm like OCD, so I'm like, nope, I don't like that. Cut that knot. We're doing it again.
Well, and that's part of where I think the plastics training comes in here, which is that you have to have an aesthetic vision.
For sure.
You've got to be able to see where this person looks like in space. So,
for sure.
So you may say that you're a science nerd, but you've got that artistry as well that you have to have for this kind of thing.
I mean, I love that is, I think, my favorite part of medicine is not necessarily the science, but the nature of it, the beauty of it.
That's right.
To me, that's the best part of it, and what
it's that almost that entangled insight that you can have of just like it's like a eureka moment of, oh, this must be this,
and 2 different people can look at the same this and be like, no, that's crap, and I'll be like, that's beautiful.
Yes, exactly.
But I think if more people agree with you that it's beautiful, then you're winning.
You're winning. Yes.
Right?
But so in these cases, like this melanoma case that you were just talking about, you have no idea really what you're getting into when you go into this. You're going to try and get margins, but you can't really. I mean, you can estimate, but you don't really know until you get down to the pathologic slide. And I would bet you've been fooled before.
100%, yeah. And by the way, when you've been fooled and you take this margin that you think is going to be appropriate, and or I'll take a margin that's more than appropriate,
generous,
based on the recommendations of all the guidelines that we use for melanoma, for example, I'll take a 1 centimeter margin and it will come back positive. I'm like, there is no way. There is no way this thing's positive. And then go again. And by that time, the patient's getting a little perturbed that you're like, what kind of doctor are you? Like, how did you not get this first time? And you're like, this is how it goes. I swear it's not me. And they're like, they start to look at you about the third or fourth time like you were inept. And you probably should not be doing this job. Exactly. And then they hear that and they're like, all right,
what did I sign up for?
Automatically discounted, like, you suck at life. Go back to writing bulls or steers or whatever you do.
Yeah, and this speaks to, there's an old surgeon mantra about how doesn't matter what you do in terms of the surgery. What matters is the scar that's left. That's what the patients are really going to pay attention to more than anything. And that's going to dictate whether or not the surgery was a success to them, despite all the other things that you had done along the way, which
totally true. Yeah,
can be frustrating.
Yeah, you can have a recurrence, but if that scar looks good,
hey, good job.
Look how beautiful this scar is. They're like, oh, Dr. Sunseri, I'm like, it came back. Like, I missed a piece. Like, they're like, no, this is gorgeous. You just go ahead and do it again, right here. Do it again. I'm like, okay.
But you can also see how technology has really helped us as it's evolved in medicine, because your eyes would look and say, well, look, I got this thing. And then the scourge of melanoma would rear its ugly head. We had to get smarter because we noticed patterns of, I took out where I thought it was, and then it came right back and did something. So
right.
We need to do something different.
Yeah, we're seeing, and I think we're just on the brink of it as far as some of the technology for Mohs and some of the stuff that we're going to see. People will be doing a lot more, I think, some injectables and doing stuff like that for tumors, which would be an interesting frontier.
Well, on that same subject, tell us a little bit about melanoma. Tell us how bad is it? Are we all going to get this? How do we prevent this? What do we do about it?
So melanoma sucks.
Yes.
I've had 2 melanomas. My mom's had melanoma, and I got that. It's these dang Irish genes, man. She gave me these dang Irish genes, like
can't go near the sun. Is that what it is?
That's right. So my point in that is not about the Irish genes, but that I think there is a genetic component.
Yes.
That being said, Bob Marley died of melanoma, acral melanoma, and nobody would look at Bob and be like, "Oh, he's genetically predisposed to getting melanoma." So genetic is, melanoma is genetically based, but also I think it's got both nature and nurture. It's environmental as well. If you get a lot of my 80-year-olds who have melanoma, it's just more prolonged sun exposure than their genetics. And turns out it has different mutations, more C-KIT mutation than some other type of NRAS, KRAS mutation, for example, that a young genetic melanoma would have. Melanoma is tricky, and it is smart, and it is aggressive and mean and nasty. It's the one thing that I feel like we will probably never get a good hold on, because there's always going to be young people who are like, I'm going to smoke a cigarette in my tanning bed, and
you can.
And I'm Irish, and everything will be fine, and fair skinned. But basically, the more moles you have, the higher your risk of melanoma is. And if you have a lot of moles, you should get checked.
Now, is that because the moles themselves, these dysplastic nevi, are going to be transitioning into melanoma, or is that just because your overall, it's a reference to the overall exposure to the risk that you've had?
The short answer is I don't know, and nobody does.
Yes.
There's a big argument that people say that there is zero evidence that having a severely dysplastic nevus will ever mean that you're going to have a melanoma, that it will ever that nevus will necessarily turn into melanoma. There's no evidence to say if you got a really bad looking dysplastic nevus, it's going to become melanoma. And so, which seems counterintuitive, because you're like, well, sure, of course it would, but there's no evidence to support that. I think it probably is just your overall melanin / fair skin ratio or something like that.
Predisposition.
Just some kind of predisposition to having that tendency to get melanoma. But like I said, you get somebody like Bob Marley getting one on his dang toe. What?
Yeah, that can come in a lot of places that you would not expect.
Exactly.
So an analogy with, something that's talked about in my household a lot, which is breast cancers, is that, as you get older, the breast cancers tend to become less aggressive. Like if you get a young person that's got some sort of cancer,